All right, so today we're going to be talking about an update on the allocation and distribution of the COVID-19 vaccine in Missouri and Kansas. We've got a panel discussion, two great speakers, as well as our moderator. So first, I'd like to introduce our speakers. First, I've got Dr. Lee Norman. He's the Secretary of the Kansas Department of Health and Environment. Thank you, Dr. Norman, for being with us here today. And Dr. George Turabelidze. He's the state epidemiologist for the section of epidemiology in Missouri Department of Health and Senior Services. Thank you, Dr. Turabelidze, for being here with us today. And our moderator, John Carney, who is the president and CEO of the Center for Practical Bioethics. So he'll be kind of leading the discussion as we go through our content today. So with that, John, I'd like to hand it off to you and we can go ahead and get started.
All right, thank you, Matthew. It's good to be with you guys today. And thank you very much, Lee and George, for joining us. There's a ton of content that we could spend a lot of time on. So we've asked them to shorten their presentations to 15 to 20 minutes. So there will be significant amount, I'm sure, depth that we will not be able to get into today, but hopefully it'll give us a nice overview of both the allocation issues and challenges that we faced throughout the COVID vaccine development, as well as the distribution of the vaccine related to not only the cold storage chain, but also kind of rural distinctions and that kind of stuff. So we'll be asking them to cover both the allocation aspects of this and the distribution access points. So with that, I'm cognizant of the time because we've got a lot of content to cover. So we're going to have Dr. Norman go first and give the Kansas view, and then we'll involve George. And then at the end of those two presentations, we will entertain questions. So thank you very much and welcome, Lee.
Thank you, John. I appreciate it a lot. And it's nice to see all of you here. Yeah, this has been quite a slog. I look back and reminisce. We're just 1 week short of having been in incident command at my agency for being 1 year in incident command. And as you guys probably realize, this is a 24/7, 365 operation. And it's really been fascinating. The way I think of a crisis is that there's a beginning, a middle, and an end. But these have been many crises, really. There's been PPE crisis. There's been testing crisis. There's been kids out of school and food crisis. And it just keeps on going. And of course, and I think of the vaccine not necessarily as a crisis, but the management of it certainly feels that way because of all the sensitivities. One of the things we did early on when it comes to the vaccine and really understanding how, from a logistical, pragmatic, ethical perspective, how do we think? And one of the things that we did early on was pulled out our H1N1 document, and there was still a lot that was relevant in there, but mostly as it related to the logistics. And logistics is tough to walk through on its own, of course, but then we had all the other considerations, seeing the disease trends in long-term care, congregate facilities, the different racial patterns. It was very obvious that we needed to get some help because one of the things that I didn't want as a secretary was to be viewed as, I didn't want to be in an echo chamber just listening to ourselves. Those of us in incident command and our leadership group working with the governor's office. So we put together a COVID advisory committee. John Carney happens to be one of them on there. Populations groups, advocacy groups, tribal units, and different kinds of folks represented. And that kind of information was invaluable and helped us terrifically in formulating the plan. I'm going to share 3 slides with you, and then I'll come back and talk about distribution. The 3 slides come right out of our off of our website. Let me pull this in. Okay. Matthew, does that show up fine?
Yep, looks good to me.
Okay, very good. Thank you. I have 3 slides here, and one of the things that, and I know that we differ from our counterparts across the line into Missouri, although my counterpart and I work there pretty closely. Every state is different, and one of the things that we felt about early on was just even in the nomenclature that people were getting bollocksed up in what's 1A, 1B, 1C. Other states have gone with that, CDC and ACIP recommendations. Governor Kelly, I think fairly pragmatically said, can't we just call it 1, 2, 3, 4, 5 if we have 1, 2, 3, 4, and 5? So that's where we wound up. And again, this is one of the slides, and you may write this down. It comes from Kansas Vaccine, that's one word, KANSAS vaccine.gov. The slides I'm going to show you, and then there's a lot more information there, talks about and how each of these is defined. But this is the phases that we're going to be going through. We're in phase 1 now with healthcare workers, long-term care, and I might add kind of long-term care like settings like Home Plus and those that have small group homes for disabled persons and the like. And then finally, in phase 1, what I would call critical infrastructure or workers critical to pandemic response continuity. Really, this I would describe it as the continuity of government and continuity of operations. And that's where we are right now with our first, how long we had, 5 weeks now of vaccine coming to our state. We anticipate by the end of the month of January that we'll start moving into phase 2. From the beginning, we went with 65 plus instead of 75 plus because we wanted to, for a variety of reasons I'll talk about in a minute. Congregate settings has been very controversial. One, what's the definition of a congregate setting? Probably the most controversial, quite honestly, has been that the congregate settings includes offenders that are in prisons and jails. And then third one is high contact critical worker. High contact means in contact with other people and in circumstances that they cannot control. The next ones are simply age group defined with medical conditions, and then finally to the rest of the population. So how do we define what kind of a critical worker is, and what are the things that we worry about in different occupations? Because this has been a subject of some and more than a little controversy. One is, as you can see, clinical outcomes and death. Obviously, looking at the elder population and especially nursing home population. But this is one also that we're very attentive to racial, ethnic minorities, socioeconomic strata. And you notice on the earlier slide, we didn't call out specific ethnic, racial, and socioeconomic status. But one of the things that, as we did the analytical work behind all this, when we got into the high-risk workers, that we found that, and we're able to stratify which of those population groups, whether it's racial or ethnic groups, fit into that. And it's interesting how those things traveled quite together. Proximity, obviously, how close are you to one another, and can you control that? In many of the settings, you cannot. Type of contact, you can see there droplets, shared surfaces, are common items that are touched. Contact duration, greater than 10 minutes. Obviously, if you're standing next to somebody, whether it's a meat packer, 33% of all the beef in the United States comes through Kansas for processing. So that was a big issue in terms of the number of cases, still is. They can't control how long their shifts are. There are certain engineering things that can be done. And then finally, challenges to implementing protective measures, space, where they're indoors or not, and whether they can control with whom they come into contact. And I'm just going to give one example of this because it reminds me to mention a couple of things. This is a phase 1, pretty straightforward. I say straightforward, it took a lot of hammering out, and John can attest to that, in each of the 5 phases, the working definitions. But we tried to be simple, and you cannot, with 14,000 different job types in about 1,400 industries or something, you cannot have an exhaustive list. And this is going to be a problem, I think, when we get into phase 2 and 3 especially. It's not so hard in phase 1 who is included, because You know who's in a long-term care facility as a resident. You know who is in a hospital as an employee or not. But when you get out beyond phase one, there's going to be some challenges. And for example, if we called out let's say a meatpacking employee as a critical infrastructure needed for food, we didn't call out, Russell Stover's chocolates. And yet people might be in the same kind of setting, side by side, in close approximation with certain engineering barriers. So people will have to use their, I think, common sense to a degree and self-selection. It'll put the immunizing individuals, the vaccination sites, I think, a little bit on the hot seat for saying, is that really a phase 2 or a phase 3 person? What we've decided, we don't, obviously, we have 300 vaccinating sites now. We'll double that in the next couple of weeks. We don't have policing actively going on at each of those sites. So hopefully there won't be a lot of mayhem result from that. And so far it's not gone smoothly, but phase 1 is going to be more smooth. I know that. I am going to stop my slides now and come back and just talk. What we're doing in the distribution has been something we're very familiar with. As I told my colleagues here before we started, that I was in a situation once, matter of fact, twice, where even influenza vaccine that wasn't handled right from a cold chain management ended up being thrown out. And we certainly didn't want that to happen with the COVID-19 vaccine, as precious and as limited as it is. So what we did with the Pfizer product, since ultra cold management was necessary, and Kansas has, like Missouri, a lot of rural counties and frontier counties. And so what we did is we determined 5 central hubs and then delivered in a spoke manner the Pfizer product out to the sites where it eventually went to. We did it different with Moderna. Moderna is more forgiving, easier to manage, and we had direct shipment of vaccine to the vaccinating sites, unless it was very small counties, less than 100 doses, and then we did all that distribution out of our emergency operations center. How's it gone? There's been a little bit of controversy. Why did we get so much? Why did they get so little, et cetera? But that seems to have worked out pretty well. I will say that the sites that get the vaccine now are primarily local health departments. We have 100. So we initially put out, and we're still pushing out 105 counties, and have vaccine to every county. Health departments, FQHCs. One of the things that we concerned ourselves about is how do people that have less socioeconomic means. We want to make sure that they have equal access, and one of the prime targets, if you will, has been the federally qualified health centers, FQHCs, aka safety net clinics, and then of course hospitals have been because of the healthcare workers being, and by the way, we just defined healthcare workers as people in environmental services, food services, et cetera, because they're delivering trays and that kind of thing. And the one we've have asked, and it's been working, I think, pretty well. Let's say in a county that has enough vaccine that the hospital or the health department has met all the needs of their healthcare workers and public health workers, and to share and to say, okay, to call across town or across county and say, we have extra, do you need any of this? And we'll move it around. And that's how we're trying to, on a cooperative venture like that, get through phase 1. Phase 1 is going to be a piece of cake, I think, in retrospect, compared to phase 2, just because of the numbers. Excuse me. So in summary, I think we're in pretty good shape. We don't know what's going to be coming to us. And big question. I want George to tell me. Over.
John, you're still.
Before we turn it over to George, Dr. T, could you briefly address the issue of the long-term care distribution through the commercial providers, Walgreens, CVS, and how that either runs in parallel or coordination with the distribution through the hospitals and public health departments?
Sure, happy to do that. I've been talking all day already, and it's only 12:20. The it has frustrated us a little bit in that we don't have control over CVS and Walgreens, and it's been a little bit spottier and a little bit slower than we wish. They're dealing with a more difficult product in Kansas because it's all Pfizer that they have, and that's part of the slowdown. The uptake of the vaccine has been lower in the residents than what we thought, and we don't know exactly the reason for that. If it's the nursing home resident themselves, if it's in a substituted competency perspective, if somebody else is making the decision for them, we don't know if it's them. And yet we've been so busy doing this process that we just haven't had a chance to slow down and say, why is it that only, I'll make up a number, but for the discussion, why is it that only 66% of people in skilled facilities are getting the vaccine? We need to find that out. The CVS and Walgreens have both been actively providing vaccine, and it hasn't gone to waste. If they've it's been repurposed, obviously, and it's been handled well and used in other facilities. So and by the way, John and group, we do have facilities, nursing facilities that are not covered by the CVS and Walgreens federal program. We have a number of independent pharmacies that have long-standing relationships with skilled nursing, and we didn't want to interfere with. We wanted to support commerce, if you will, but we also wanted to assure that vaccination got into people's arms. So we, out of the state supply, have been supplying those pharmacies that have independent relationships with nursing facilities. We are in the process, matter of fact, earlier today on with Operation Warp Speed and CDC on using community pharmacies. We're going to expand to the Kroger's and other kinds of Hy-Vees, so that we will have a lot of community pharmacies throughout the state of Kansas as well that will be in the next wave of vaccinating sites. The last one, I guess, or there's never a last one on this topic, but the mass vaccination, we feel that the communities that have population size to merit it, that this is kind of like getting the band back together again from H1N1 in terms of gymnasiums, National Guard armories, livestock barns, and the like for setting up mass vaccination clinics. We've taken and had trial runs on that, and we haven't had to stand those up yet. We've had hospitals that have been on 1,000 or 1,500 a day, and it's been, I think, overall, but to flex up, I think it's going to be an interesting time with outgoing President Trump and incoming President Biden. We don't know what to expect, quite honestly, because we're hearing contradictions coming from the feds. I don't know if to next week expect 35,000 doses or 250,000 doses, which makes it an interesting planning exercise to not even understand an order of magnitude or not. Yeah. So we'll get back to you on that. It'll be a big deal.
Okay. All right. Thank you, Lee. George, you want to go ahead? I don't want to spend any time introducing you. We got plenty of ground to cover, so go ahead.
Thank you, John. Yes, I am George Turabelidze, Missouri State Epidemiologist, and I want to thank you, John, for inviting DHSS to this forum. I think that education and especially transparency of what we are doing is very important to have a successful vaccination program. So Matthew, if my slides are available. Next. So what are priorities and approach that we have taken in Missouri? Next. The reality of the situation we are dealing with, and all other states essentially, is that initial supply of vaccine is limited. So until the vaccine supply is limited, we cannot give it to everyone who desires vaccination, and there are many of those. and we have to prioritize groups which would receive earliest allocation of the vaccine. But the ultimate goal in Missouri, as I'm sure in Kansas, is that everyone who wants to be vaccinated in Missouri should have the chance to get vaccinated sooner or later. Next. The priorities of Missouri vaccination plan is overarching priority is saving lives. And overall, our priorities are in the following order. Number one is saving lives, reducing hospitalizations, and keeping Missourians safe. Number two is preserving essential functions of the society. And number three is accelerating equitable economic recovery. Next. We are guided by the same ethical principles that when used by advisory committee on in immunization practices, which include the four major ethical principles, which is to maximize benefits, minimize harms, promote justice, mitigate health inequities, and promote transparency. Next. In order to have a plan that everybody is involved with, and we have advisory board that helps us to have a representation, as wide representation as possible for the entire society in Missouri, and that includes local health departments, Missouri Hospital Association, Missouri Nurses Association, Missouri State Medical Association, Hispanic Chamber of Commerce, social empowerment organizations, Urban League of St. Louis, disability right activists, long-term care organizations, other congregate care setting agencies, economic development agencies, and many others. So we have quite a wide representation in our advisory board that helps us with planning for the COVID vaccinations in the state. Next. Our plan envisions sequential vaccination rollout. We are essentially deep in the phase 1A, which includes vaccinating healthcare workers, healthcare personnel, and residents of long-term care facilities, and includes also urgent care, includes congregate healthcare settings, and the vaccinators themselves. Now we essentially already entered phase 1B, which includes individuals with high-risk conditions for severe disease and critical infrastructure. We have 3 tiers in phase 1B. Unlike Kansas, we decided to stay more complicated. We don't have 1, 2, 3, 4. We're still using alphabet. So it's 1B, and in tier 1, we have emergency services and public health. We have tier 2, which is the high-risk individuals for severe disease, which basically includes persons 65 years old and older and those with comorbidities. And tier 3 is the critical infrastructure and continuity of government. Then we envision moving to phase 2, which will serve equitable economic recovery. And we're certainly looking at disproportionately affected populations who need vaccinations. We look at remaining critical infrastructure and at the institutions of higher education. And the final phase, phase 3, is for everyone who desires to be vaccinated. Next, please. So how does it look in real? How many people are in those phases? So you can see that our estimates are that in phase 1A, we have nearly 500,000 people. In phase 1B that we already literally moved in, we have emergency services category that there is about 200,000 people. And then the high-risk individuals, that category is nearly 2.5 million people. And moving to the final stage of from phase 2 to phase 3, that's nearly 3 million people. So that in a sum is the overall population of Missouri, over 6 million people. Next, please. So what is a delivery model that we are trying, we implemented? One is what we call vaccine comes to you. This model is employer initiated. Employer contracts with some third-party vaccinator. The vaccinator screens persons, confirms that their eligibility, employee receive vaccination, and the employee is vaccinated, completed. Next, please. What we call you go to the vaccine. This is the model that is initiated by the individual. Individual makes appointment with a provider or the pharmacy. Pharmacy or the provider confirm eligibility, and individual receives vaccination. And next model is the community events. Whenever community event is planned for vaccination, individual initiates finding the event, registering for the event, and then that individual is approved for his eligibility, and then individual receives vaccination. And next, please. So how do we do eligibility screening? Anyone seeking vaccination they must provide a verification of their eligibility according to the tier which is the phase or tier which is activated. Screening form allows citizens to be vetted into the phase and the tier, and that screening document form is the only document that will be required for their verification. So the citizens in Missouri have to do their part, which is self-indicate their eligibility, attest that is truthful. Those forms are already available at the mostopscovid.com. They're also available at their vaccinator, and they're integrated into their vaccinator's electronic registration system. If individuals are signing up directly with a provider or pharmacy, they will need to complete they will not need to complete a separate screening form on the state website unless directed by their provider or pharmacy. So that's regarding eligibility screening. Next, please. And this is a slide I wanted to include that this is literally update from this morning. Today, we actually activated phase 1B tier 1. And on Monday, which is January 18, we will activate phase 1B tier 2. We will still continue to vaccinate all individuals eligible in phase 1A. Since there is as Dr. Norman was saying, we also expect that federal government may increase supply of the vaccine if they do adopt a different approach of not holding any vaccine back for the second dose and just shipping everything. Then we will expect that is possible. We will get a lot more than we're getting right now. And because of this anticipation, we are activating next year to ensure as many people vaccinated as possible once the supply increases. And we're also telling 1A vaccinators, if they have available supply, they can also begin vaccination for phase 1B tier 1 and tier 2 individuals. Next, please. Those slides are for the presentation, for the person, any interesting person who is listening to this presentation. You can see those sources of information here if you are interested. And next slide. And information for businesses as well. And I think that's it for my presentation.
You're still on mute, John.
Yeah, okay. So thank you very much, both of you. Appreciate your timeliness here. So we have a good almost half hour that we can spend curating questions and being able to address the concerns that are raised. I just, Matthew, you want to clarify how you will make Dr. T's slides available? I know they're not going to be available on the website when we post this. So would you, because a number of questions have come up, George, about how they could access that information. And I know they're not going to be published on the website. So go ahead, Matthew, how you're going to.
So the recording of this video will be published on our YouTube channel. If you're interested in receiving a copy of the slides, you can contact me directly. I'll put my email address in the chat here. And I will send a copy to you.
All right, and then for Dr. Norman's slides, they are on the website already in the information that we provided you. So we have a number of questions, I think, that are coming in over the Q&A. One is from Hillary, who's asking, is there opportunity for social service providers to access employer-sponsored vaccinations? Well, when will that come? And how is that different than the regular process that'll be going through the departments or the commercial providers, the pharmacy providers?
I can answer that on the Kansas side. And the same question comes up with psychologists and case managers and the like, whether they're in a hospital or a community practice type setting. I think if I'm answering or understanding the question right, we consider those to be healthcare associated employees or healthcare associated, or it's enough like that we have been vaccinating those people right along in phase 1 along with the healthcare providers. We realize that they're not necessarily healthcare per se, but it acts like that. And by the way, I should have mentioned that we also put emergency medicine providers, paramedics, EMTs, and the like in phase 1 as well. Over.
Okay, a follow-up question on George. I think you mentioned that there would be these kind of how do I get in line? How do I register? And there's so the question that a number of people have asked is, so I want to be able to do that. And I know that Jackson County and Johnson County now both have live websites where people can go in and say, where do I fit? When am I able to get in line? And I guess the question is that for as you break it down in terms of state, county, and community, those opportunities to get in line, are those going to be sponsored at the state level? Will people be able to go to one location and then see where it is that they need to go get in line? Or is that something that will occur at the local level and the community will send out a notice saying, hey guys, for our region, go to this website and this is what we'll do? How does that work from the state all the way down to the community level?
The vision for this is that that eligibility form that I mentioned, which is basically developed, we were still finalizing this form as of yesterday, but it will be posted online on that Missouri State government website, and this will be the only form the individual will need to complete. And take this form to any place where you will go for your vaccination. This will be the only form required for the verification that you are eligible for vaccination.
And will the state, and I think, Lee, this is a question for you as well, the state will stay at a either phase tier level until the state entirely moves to another one, or will it by region move to the next level?
Yeah, two responses. I'm going to respond to just similar to George prior. We decided early on at the state level that we did not want to run a scheduling program because between having urban, suburban, rural, and frontier, it was a little hard to know exactly with the vacillating vaccine amounts coming in. We couldn't feel like we could have a high integrity state system like they have maybe in New Mexico or I think maybe Tennessee and some other ones have that. So we have the county by county, and the county health departments are taking the lead on this. What was your question, John? Sorry.
So if there's, are we going to be able to stay at the same level, the same tier, and then the whole state goes, or is it by region?
Yeah, overall, overall, we don't want regions to lag far behind and other regions to go far ahead, because again, when you think of where the prioritization comes from, it's pretty sound advice that it's because people at the greater risk, we want to be covered first over people at lower risk. So that's the fundamental. In reality, it won't be quite as clean as that. For example, we already have one county that has kind of started inching into phase 2. Their surrounding counties didn't need the vaccine, and they're going to be moving into the next phase and have actually started moving into the next phase. So it'll be mostly in sequence, but not 100% lockstep. We felt that was a little too heavy-handed and impractical, but that to reach out to your neighboring cities or counties, if you have excess, if you don't, there's not a lot of receptivity because they don't need it, they're getting ready to move on, then move on. The caveat was we didn't want people holding back a lot of vaccine, waiting and kind of squirreling it away for when they move into the next phase. We were hoping for goodwill and community spirit to prevail, and we'll see if that holds through this.
All right, I have a follow-up question for that, but first I want Dr. T to answer the same question. So go ahead, Doctor.
Essentially, Missouri is the same. We always traditionally, historically have a lot of autonomy in our regions and counties, and they move in their own pace. We do announce when the phase, when we are entering phase, like today we are saying that now we're in phase 1B, tier 1, so everybody knows. But if some county makes the progress more advanced than the neighboring county, they are free to move to the next phase as long as it's already decided what eligibility is for that phase. For right now, we announced tier 1, and then when time comes, we announce tier 3, we will announce phase 2, and that's how they move, but they will never gonna be exactly in the same stage, and they can move at their own pace.
Okay. Thank you. Can we talk a little bit about hesitancy, reluctancy, and I think Lee, you kind of mentioned earlier that the refusal rates, and I want to clarify refusal rates. I know we had a national meeting of the bioethics directors where people were getting captured into refusal when in fact was a problem with scheduling. They couldn't make themselves available at the time that they were scheduled, and so it got counted as a refusal as opposed to a deferral. We've had other people who said, you know, I don't want to be rolling up my sleeve when there are people in who need it worse than I do. And so those have also sometimes been counted as refusal rates. And so we see that refusal rate going up. But we do know that there is hesitancy. We do know there is reluctancy in certain populations. How are you addressing those issues, and how maybe can our listeners and the participants on this call facilitate your efforts in making sure that we reduce any of those barriers that may exist for the certain populations that we're serving? And I'll leave that to either one.
Okay, sorry. We try to approach it that there's active refusal and that there's deferral. And we've been seeing, I think it varies a little bit, but we've been seeing about equal amounts of those actually. We've had, I was on a call with a bunch of hospitals the other day, and one hospital, there's a small hospital, only 36% of their people, of their employees chose to get the vaccine, which seems quite low. And a lot of those were deferrals. We had other ones that were more in the 70, 75% have already gotten the vaccine range. In terms of what to do about it, is one, we let them back in anytime. If somebody has watched for a month and they say, okay, so they're not deferred for life, or they're not refused for life if they change their mind on that too. And the biggest challenge, I think, and we've tried a lot, is to not have global messaging and not have Pollyanna messaging, oh, it's safe, you'll be fine, it's the greatest thing since sliced bread, but rather to have a very targeted approach, different languages, different kinds of people talking about it, different races and ethnicities. And it's taken a very laborious and a fairly large amount of money, I might add, to do marketing and communication campaign that are as targeted. And time will tell where we wind up. I think I mentioned to you yesterday, John, when we talked, that I did a piece with on Telemundo in the Spanish language, kind of Facebook Live throughout the state. And it was really well, I mean, I'm clunky, I don't speak Spanish, so it was a little clunky going with it through an interpreter. But it got really great remarks from the viewers. And it was just fascinating to me the questions we got. That I would, if you would have said to me, Lee, come up with the 15 questions that they'll have, I would have been wrong on 12 of them. So there's nothing like pressing the flesh and getting out in forums with the various populations, and it's really important to be invited in.
Thank you. It's good to hear. George?
You know, we are practically in like halfway in phase 1A, and we are just entering 1B. So to make kind of generalized the general statements of what is really happening would be preliminary, but we certainly see some trends. And one of the trends concerning is that in some places, not in all healthcare facilities, but in some, there is reluctance on the part of healthcare personnel to get vaccinated. And when you ask them what the reason is, the fear of the safety, especially in a young female population who are worried about, for example, fertility. And that those unsubstantiated rumors are surprisingly persistent. And all you need when you are against vaccination is to plant a seed of doubt in someone's mind. Unfortunately, those seeds can grow really strong and for a long time before we can exterminate that. And the only way to address it is by education and being persistent. So we have not only information on our website, but we have several video presentations which address exactly every kind of rumor as it is on the social media or on the internet. And we direct all healthcare workers, public health workers, government workers to all those videos to watch and to hear from credible people why that is not true, or it's partially true, or it's misunderstood, or whatever. So as Dr. Norman was saying, we are persistent. If somebody is refusing or deferred today, we're going to come back to them again tomorrow. And I'm sure in the end, we will increase the percentage of vaccination of among healthcare personnel. When it comes to nursing home residents, so far we can't really say that we are disappointed. Many are accepting vaccinations and being vaccinated. We are probably going to largely shift to federal pharmacy assistance, federal pharmacy vaccination through pharmacies. That will be the bulk of the administration within the nursing homes. And we expect that as more people get vaccinated, that kind of setting example giving people reassurance that vaccination is safe and even more people will be vaccinated.
Yeah, I think both of your points earlier around transparency, though, is important to underscore here. So not all population groups, not all subpopulations cohorts have been tested. So the concern that's raised by young women who may be childbearing, that cohort has not really been studied, well. And so we're in emergency use authorization. We are not in an FDA approved setting. So there is the issue of the cautions that people have are legitimate. And you both mentioned the important role of transparency to say, yes, that's true, but here's what we know to date. And as you said, both of you have said, this is going to be continuing to go. So we're going to get more data. We're going to be able to collect more, but I think everybody needs to be upfront about the fact that this is emergency use authorization. This is not an FDA approved, rollout. So I think either one of you have comments on that. I'd be appreciated here.
I want to amplify one more thing that George stimulated a thought back to the hesitancy. I've been a family doctor for over 40 years, and so I've dealt with all manner of different kinds of enthusiasm and lack thereof for vaccines through the years. And one of the best things that I think I've come to a conclusion is that people get vaccinated because of fear, and they refuse vaccinations because of fear. And one of the things that I think that I do as a doctor, and I think that we all can do as public health and other kinds of persons, one is to say, let's talk about what we're both relatively afraid of and see if we can meet in the middle on how to define ways to mitigate fear. A second thing, and I think it's really clever what we've done, and it wasn't my idea, but it's clever anyway, on the Kansas side, was that we have an entity called the Kansas Leadership Center that has brings in people from all sorts of business and healthcare professions and government and it's a year-long training sequence about leadership. And they have I don't know, 14,000 graduates or something. So we mobilize these foot soldiers because they're in every county and every community with and have scripts and they're hosting what I would call town hall meetings to have these kind of discussions facilitated. And it's a fascinating dynamic when somebody that might be not a COVID believer or anti-vaccine, what they hear from their faith leader or they hear it from their the school superintendent or what they hear from their clinician or what they hear from a business leader in their own community that they know and are very familiar with. That's a different kind of message than coming from an epidemiologist because it's almost a word association game. What do you think of when you think of science? You can think and I think it's a certain way of facilitating conversations. And again, it's laborious, but it's local. And I think it's been a success so far. We'll see.
Yeah, we're going to need to enter the lightning round here. We've got about 8 or 9 questions. I think they're still in the queue. So if we could quickly cover those, either one of you can jump in to answer these questions. So the first one, I'm going to start at the top. What state support is available smaller FQHCs and hospitals with limited workforces for vaccination?
In our state, they can go to the health department or FQHCs or any of the vaccinating sites. A lot of our hospitals vaccinated clinicians that are not on their medical staff or are not employees.
George, you have any comment there?
So as a vaccinator, everybody is invited to apply to become a vaccinator, and nearly all healthcare facilities in Missouri are vaccinators, so they can be vaccinated by their employers because they are vaccinators. So it is we made substantial progress in vaccinating healthcare personnel. We are way advanced in large healthcare facilities. We are a little bit behind in the smaller healthcare facilities, but we are moving ahead and we are making progress irrespective of the size of the facility.
Okay, from Jennifer, when will we know when we are getting additional vaccine for hospitals in Kansas? Missouri is allowed to request. What is the plan for Kansas?
Well, it's the same as Missouri. We all have the same marching orders, and that is we put in a request and then we get some portion of that. We put it in, it's always 2 weeks in advance. We're asked 2 weeks in advance to put in, and that's what we do.
All right, thank you. This is next questions for both of you. Why is there such a wide gap between distributed vaccines administered in administered vaccines? Missouri is today ranked number 40. We talked about this earlier, I think, before the call, with just 31% administered. Kansas is highly marginally better. Where specifically are the obstacles to higher administered numbers? West Virginia, I think there was a story on NPR last week about how wonderful they're doing with 69%. What are the top states doing and what are they doing better and what can we learn from them?
Regarding vaccines administered, ranking depends on what you include. If you take only 50 states and District of Columbia, Missouri is actually about 31, 32, something like that in vaccine administered. But you cannot administer vaccine if you don't have it. And when it comes to vaccine distributed, Missouri is even way lower. So you simply need more supply to administer more. But that still does not answer the question why we don't have everybody vaccinated when vaccine is available, for whatever vaccine is available. And unfortunately, some facilities are moving at the better pace than the others. And these are since we have most experience with phase 1A, so these are healthcare facilities and nursing homes. So these are the specific places where they need to accelerate and improve everybody's numbers.
Kansas, very, very similar. Our 2 states, I think, are alike in that we pushed it out very broadly, including in our case of Kansas, 105 counties. If you want to be the most efficient at getting vaccine into arms, you send it to about 5 hubs in the biggest counties, and you can get vaccine in very quickly. And a lot of the states that have higher rates of vaccine administered compared to what's distributed are much more population dense states with many fewer vaccination sites. In Kansas, it's mostly data input that lags behind.
Yeah, and just a clarification too on the NPR story, they did note that in West Virginia, they did not use the commercial manufacturers, Walgreens and CVS. They used a local state, and that option was exercised by the state early on. So it changed the actual administration, especially to long-term care setting. So just to clarify that point. So Dr. Rajadiga asks, many communities are far behind in setting up mass vaccination sites. The current vaccines make it impractical for the physician clinics to take up the burden. Are there any talks about the National Guard or other kinds of military responses, or do we have to wait until Inauguration Day for some of that to sort out?
I don't know about, oh, go ahead, George.
Sorry. Yeah, right now, I don't have any information about the immediate, that this is potentially on the table. We are not saying that something like this is going to happen next week. But again, when you receive only like 35,000 doses of vaccine, 1 week of Pfizer, and then Moderna, maybe 60,000 or 70, whatever they will send us, it's hard to plan real mass vaccination clinics when you have only 35,000 of Pfizer coming this particular week. So you need much larger stream coming so that you can really arrange mass vaccination.
Yeah, we have mass vaccination plans in place, but we don't have mass vaccine. If we could build it and have in some communities 100 doses or 50 doses or 20 doses even. So we need more vaccine, but we've got plans in place to do that. And the National Guard, I'm a National Guard, I'm an Army colonel in the Kansas National Guard and the Army State Surgeon of Kansas. So I happen to know a little bit about this. And that is the funding opportunities are not coming to us from the National Guard Bureau for vaccinating at this point in time. We would love it to be the case, but the money is not there from the feds.
But
yeah, go ahead.
Just to supplement, regarding National Guard in Missouri has been a kind of lifesaver for public health and entire emergency response in the state. They've done a lot in terms of going out to facilities, testing, sampling, and doing a lot of activities that public health alone would have not be able to handle, especially on the emergency basis.
Yeah, and that reminded me, we did have a meeting earlier this week with COVAC, and they indicated that with the new distribution of monies, the monies that were just made available in the most recent allocation by the Fed, states do now have resources that they will be able to help address some of the needs that we have with the hardest to reach communities. And there are plans to deploy that money for those resources in those community-based organizations. So hopefully that'll help alleviate some of the issues around what they call the language line and those kind of things that obviously affect Latinx populations. Eric asks, where does homeless shelters in Missouri fit into 1B, or do they? Will on-site programs be available? And who do we connect with for FQHC or health department? That's a Missouri question, I believe.
Yeah, homeless shelters are considered congregate settings, and they are in 1B, and I think they are in tier 2, if I'm not mistaken, but for sure in tier 3. So yes, they are considered.
And the connection to FQHC and health department is online. Is that how they find out about those resources?
I'm reading the question as, who do we connect with? Is it either an FQHC or?
Oh, I'm sorry. Thank you, Matthew.
For the shelters, you mean?
For the homeless shelter, yeah, the folks, that population.
The shelters should work through the local jurisdictions, local health departments.
Okay. I hope that answers the question. Terry asks, in the Missouri plan, where are incarcerated persons empirically a vulnerable population to this virus due to congregate living? In the Kansas plan, which acknowledges the vulnerability, the objections have been lodged by opponents. What objections have been lodged by opponents? Thank you to both of you for excellent presentation. So I think the first part is George and the second part is Lee. So George, you want to go first? Where are incarcerated persons empirically?
Same thing, they are in the same category, congregate settings, so they will be the same priority as we just mentioned for shelters, prisons, Department of Mental Health, congregate settings. They're all in the same category, and they're in phase 1B.
Yeah, we ditto for the Kansas side. We number it different. We're in phase 2. They are in phase 2 congregate settings. And you're right. The court of public opinion has not been kind to us on this, and yet we've stayed firm. The one thing that's been the saving grace, quite honestly, and it's kind of a marketing twist, is that those communities that have prisons understand that the prison is not an island outside of the community, with all the work release programs, with employees coming and going, and there's a lot of disease that goes into the community. There's a lot of disease in the community that goes into the prison. They are not an island, and so they need to be treated as a congregate setting, and that's where we put them.
Okay, just to make sure everybody understands that we will make the slides from Dr. T available. You'll need to do that by request. And so we'll make sure they get out to you. And Matthew can send something out to the folks who register to alert you to that. Also, a final question then is, it's not clear to me in Missouri where the individual goes to find what providers are providing vaccination. Is that at the county level, the state level? So I guess, George, it's back to the kind of question about the website, how they just go to the website and find out about that.
Yeah, we will be publishing all the vaccinators that are approved to give vaccination. So any individual can find a vaccinator that is someone that is in their geographical location, or the vaccinator that they aware of or know of or they are patient of. So and according to the list, then they can approach the vaccinator and request the vaccination.
Thank you, guys. This has been terrific. You're coming in right under the buzzer. Matthew, anything that I missed or that needs to be reiterated to the group?
Just thanks again to both Dr. Turabelidze and Secretary Norman for contributing their time to this excellent program. And just like to remind everyone who's on today that we've recorded this session and you can find it on our YouTube channel. So if you go to YouTube and search for Practical Bioethics, you'll find us there. And as John mentioned, the slides are available at request, and you can find my email address in the chat. So yeah, just thanks again. We've got great program lined up for the rest of the year, so stay tuned. You'll see more about that soon. And we will see you next time. So thank you all.
Lee, George, thank you very much. Appreciate it. Great job.
Thank you.
Thank
Bye-bye.
you. Thank you.